I hope you all enjoy it. Can you all hear me and see my screen? Oh, did I press record?
Yeah, I can see and hear you.
Amazing. Thank you. Oh, I did start recording. Silly woman. Okay, right. This lady is a Gravida 7 para 4, 4 previous SVDs at term, alongside 2 previous miscarriages. She has a history of PIH, but I don't believe she was ever medicated, incontinence, and then some fitting during previous pregnancies, none of which was ever actually sort of proven, not in the right word, but none of which was sort of identified as being a massive issue. Medical history wise, she's previously had hand surgery and has wear and tear back pain, and also a history of 2 previous cardiac arrests in 2006 and 2010. She has a hernia. She was asthmatic from childhood, and her latest ultrasound showed 27+5, normal scan, placenta was posterior high. She is a significant class A drug user as well, and was using throughout pregnancy. So just bear that in mind when we are going through what we think this fetus is telling us. So she comes into triage on the 11th of the month. She's 36+4. And what she tells us is that she actually shrom the day before, so 36+3, at 2 p.m., but hadn't got round at that point to sort of coming in. Dawes Redman, as you can see, has met criteria at 14 minutes. We confirmed her shrom, and basically a second midwife looked at this CTG, or I think they took another look at this CTG and thought, despite the fact that the Dawes Redman criteria has met, we need to restart it. We need to put it on again, because I don't know about you, but does anybody else seeing a slight wandering baseline here?
Yes, definitely.
Yeah, totally agree.
Met, then unmet, then met again.
Yeah, exactly, which just confuses me. And Dawes Redman doesn't have a lot of evidence out there for what to do when we go from met to not met to met again. There's clearly something that was going on, but then it picked up again, which I find a bit confusing. Also, from what the Dawes Redman has said, it said that the baseline here is 124. But I don't know if I would agree with that one, just purely based off of the fact that in the whole 15 minutes that we've got here, it spends about 3 minutes in total at 124, 120, but the rest of it is kind of all over the place, quite frankly. Anyway, I'd probably go more along the lines of this is a baseline of 140 with some decelerations, but I don't know if anybody would agree. But it's definitely one that we would want to keep on for a little bit longer just to better determine the baseline, isn't it?
Do you think the machine thinks it's like a baseline of 120 with and those are like long acceleration periods?
Yeah, because if you look at the criteria, it actually says that there's 6 episodes of high. And our long-term variation is normal as well. So this machine is clearly sort of thinking, oh, this is a normal CTG with episodes of accelerations. But this just goes to show, just proves our points that we talk about a lot, is the fact that our eyes and our knowledge is so important when we're looking at these sorts of things. And as fantastic as it is to have this technology, you know, we can't always rely on it, because I mean, this could well be a baseline of 124 with accelerations, but I don't know whether I get a bit itchy when I look at this, to be honest. So yeah, definitely would have kept it on for longer. Anyway, when they try to restart it, these midwives in triage, the patient declined further monitoring, and I believe she left the unit momentarily at this point as well. So this is at 5 o'clock in the morning as well. So she comes back. Apologies for the very poor quality trace here. So the CTG was restarted about 2 hours later, because that's when the patient came back into the unit. At this point, they hadn't had a sort of obstetric review or anything like that, but just because of her medical history, her plan made by the midwives, but wasn't sort of seconded yet by the obstetricians because they didn't get around to seeing her, was that she needs to be admitted for monitoring as opposed to doing our usual SHROM protocol. sending her home. She's also preterm as well, so she needs to be an inpatient and preferably be on labour ward essentially for further monitoring if she's got a history of cardiac complications as well. Very, very poor quality CTG. We definitely had some paper jams going on here. But this one also met criteria at 10 minutes. Whether or not that actually continued, I'm not 100% sure, but they did restart it later on. But if you can see what I'm seeing here, at around 7:50 in the morning, that looks a little bit to me like a deceleration. And I'd actually argue that we've still got a baseline of 140 with these sort of prolonged looking chemoreceptor decelerations as well. But because it's so unclear, I'll move on to the next one. We finally got a better quality looking trace, and even that wasn't fantastic. Dawes Redmond was started again, and this one definitely didn't meet criteria. So at around 8:22 in the morning, the emergency bell was pulled, and we had some significant difficulty identifying the fetal heart rate because it was also at this time the same as maternal pulse, which was done manually in triage. And just based off of the fact that this CTG was so difficult to see, we also did use a scanner here as well that confirmed a bradycardia. A decision was made for a category 1 emergency cesarean section. So a 2222 went out. Now, you may be thinking, oh, why have you chosen such a short case? But actually, just you wait. So, because of obviously we've got our bradycardia here that does last for almost a longer period, well, it does last for 10 minutes, otherwise it wouldn't be a bradycardia. We've got somewhat variability, but very, very, very hard to determine in this case. Also, bear in mind this woman is a para 4 previous SVDs as well, with no complications in pregnancy other than sort of drug use. But other than that, all of her midwifery appointments had all been pretty NAD, and there'd been no concerns with sort of fetal well-being at all at this point. So it kind of came out of the woodworks very randomly. Anybody got any ideas as to what they think might be causing this or what might have prompted this?
I was just wondering, Cara, what kind of drugs were her tipple? Like, was it cocaine, or did she was it maybe that she was into if it was heroin or something? Because that's obviously more of an opioid. Just wondering if that's the difference.
Crack and heroin.
A bit of a mix. Fair enough.
Mm.
And what was what was her uterine activity? That was
pardon?
Anything going on with her uterus?
I think there was some tightenings going on, but none that she was started to feel them, I think, at this sort of section. And she said that she was feeling some uterine activity, but nothing that would make her think that she was in labour at this point.
That's what I also wanted to find out. And do we know her BMI?
It was normal, like 20.
Okay. Thank you.
Perfect. So we go to theatre. Oh, what's going on? There we go. So we get into theatre, and this is what we see. So she goes in with all intent to do a category 1 under GA, and this is your CTG trace now. So at 8:47 in the morning, because of the fact that the CTG looked like it was looking very well when we went into theatre, the consultant was present and did an examination and found her to be 3 centimetres dilated. And in view of the recovery, the decision was made, obviously, not to continue with a category 1. But after a little bit more of a prolonged period of time in theatre, the plan was made to transfer her to labour ward for some further monitoring and a sort of more sit and wait approach. So again, we're stuck with the same question as to what is our baseline here. So if we go back to the original Dawes Redmond criteria that we had when she initially came into the unit, it sat at around 100 and the Dawes Redmond said 124 with possible accelerations. So my question to you is this a baseline of 120 with accelerations? Or do we think that this is still actually a recovery from that previous bradycardia and our baseline is at 140? There's no right or wrong answer, by the way, so just shout it out, whatever you think.
It's a tricky one, but me, I would think, or I would say it's a 140 baseline. So baby's trying to get back to its normal 140, or is struggling.
Yeah.
I would be more inclined to think that if I get 30 minutes here, that at least 20 minutes of it is 120.
Yeah.
So and the deceleration that goes in the middle here at 0843 or something
Yeah.
goes to down and goes up again to
Yeah.
become, yeah. So I mean, it is 120, 130 kind of, but not 140. Yeah.
Do you know the other thing I was thinking when on reflection on this case is the fact that when we've had a bradycardia, what we would normally expect is to see somewhat of a rise in baseline, as in the baby is essentially trying to reoxygenate itself, and quite often after a bradycardia you'll see a rise in baseline just while the body is basically trying to catch up with the oxygen deprivation that's happened before, which doesn't happen in this case. But also, when we have a prolonged bradycardia, what we don't often see is such good variability in the recovery from it either. So if this was still for the first 10 minutes of this trace recovery from a bradycardia all the way up to 140, I don't know if our variability would be as good as this, which was another thing that I just thought it would be good to add in here. We've obviously got another deceleration at around 8:52 in the morning. But at this point, I think, correct decision absolutely not to go for category 1. And yeah, we kept her in theatre for quite a long time just to reassure ourselves that this baby was back at baseline. And that was the decision that was made at the time. So she's then transferred onto labour ward, and just due to the preterm SROM, we gave her some IV Benpen. This is from 9 o'clock in the morning up until 9:50. So again, what we see here is probably a baseline of 130, 140 in certain areas, alongside these lovely looking decelerations that somewhat correspond with our uterine activity, but at the same time don't. But BE was performed at around 9:34 in the morning. This was also, I believe, by the consultant, and she'd actually made progress at this point as well to 5 centimeters. We gave her pre-meds just because the CTG is not giving us anything that's particularly fantastic, but we could actually argue that this is a stable baseline with good variability either side of in between those decelerations, which is exactly what we look for when we're trying to interpret a CTG and we're trying to, say that this baby is not hypoxic. We've also got some lovely overshoots after our deceleration that just essentially show you that this baby is definitely struggling to compensate, but at the same time is returning back to a solid baseline with good variability. Anyone got any comments?
And the membranes are gone, absent?
Yeah, so she came in with SROM. So she
Yeah.
SROM yesterday at 2 p.m.
I guess the only thing maybe to say is that the variability overall is really good, but you can just notice as well within those D cells, the variability reduces at that point. Again, nothing to get immediately panicked for, but you would again think about those early stages of is it gradually evolving hypoxia? We'll see what happens next. But yeah, those are concerning characteristics, I suppose.
Yeah, absolutely. Also, I'd love to know what's going on with her uterus, but I know full well that this TOCO was readjusted about 30 times. So is this, if we think about the sort of signs that can come along with uterine irritability, we think of things like UTI or infection. Or sometimes we can see this if we're having an abruption. Now, there was no bleeding. The Lycor was clear at this point as well. So I'm not quite sure what was really going on with her uterus. And unfortunately, we had no palpation of contractions at this time either. But she was given gas and air because she was increasingly more uncomfortable here. And obviously now we've classified her as being in active labour. So this is your next segment here. Anybody want to add anything? So she's 5 centimeters. Like we said, she's a para 4. A previous bradycardia, which did recover to an extent. And then, yeah.
The details are becoming wider and deeper.
Yeah. What does that indicate? That's quite indicative of worsening hypoxia, but they're not with every contraction. And we've still, again, got a baseline that's stable and variability that's normal in between those decelerations. So although we're looking at this from a, well, we know something's got to happen kind of picture, at the same time, what we're looking for that's reassuring is what's happening in between those decelerations. My thing here with these decels is the fact that there is absolutely no variability within them. It's almost pencil tip within them, which doesn't give me much reassurance. But in between them, that's where we stand. We'll move on. This is your next section. What do we think of that one?
There seems to be a sudden increase in kind of uterine activity at that point as well, which given with the very slow recovery of that deceleration.
Yeah, absolutely. So she's examined again at 10:44, and we're still sort of 4 to 5 centimeters. Would anybody like to do any actions on this at this point? Is there anybody here that's thinking, should we just take her to theatre? Okay. Well, this was de-escalated as the CTG recovered, and then I'll show you the next section. How about now?
Yeah, what's that baseline doing?
God knows.
Just because maybe it's starting to look like it's rising as well.
Yeah.
Thinking in my head about the fact we've got prom, and obviously she's premature as well, so it's not, you know, maybe that much of a significant rise in baseline yet, you know, over maybe that 10%, but it's definitely, it's at some points creeping up, and then that's an odd looking babe trace. I know that's not the medical term, but
But you know what? This is where we get stumped, because
yeah,
when we think gradually evolving hypoxia, we think, okay, possible loss of accelerations. We think we've got baroreceptor decelerations. We then somewhat move on to chemoreceptor decelerations, and then we get our rise in baseline. And that's the sort of stages, if you like, before we then end up with reduced variability and a very, very, very poor neonate. But the difficulty we've got with diagnosing at what stage of the gradually evolving hypoxia we're at is the fact that we don't really know what our initial baseline ever was, because it was so wandering and because it was so like undefinitive. How do we know whether this is a baseline rise or not? Because actually here it looks like 140, 150, sort of 150 in the beginning, and then it goes down again, and then it looks like it's on the rise again towards the last sort of 5 minutes. But if our baseline was 140 initially, then that's technically not a rise in baseline. But at this point, she's obviously still 5 centimeters, sort of 4 to 5 centimeters. This baby is clearly giving us some kind of indication that they need to get out of here. Anybody have any other comments or anything they want to add?
The contractions, I can see the TOCO is zeroed, and there's like 1, 2, 3, 4. Is there any comment about the uterine relaxing in between, or what's happening to the contractions?
So there's no comment on the amount of contractions. I think it was reported within the last half an hour that it was about 2 in 10. But we've still got quite, from what we're seeing on the machine, we've still got quite an irritable uterus, don't we?
Yeah.
So this is the next bit, just while they're preparing theatres, and this is our CTG now. So we've definitely got a baseline of 150. We've got these decelerations that are present, and there's not really concording with any kind of uterine activity. They're not quite quick to recover, and there's no variability within them. Because of this woman's medical history of the cardiac complications, we tried to get a second cannula in, which was very, very difficult. And the first bag of fluids was started just essentially to hydrate this woman prior to transfer to theatre. This was not a bag of fluids to fix the CTG, because we all know full well that if we've got episodes of hypoxia, a bag of fluids is not going to fix it. But that was essentially the plan at this point. I can't remember if I've got I do. Starting to worry. Hadn't asked you the question as if you want to guess the gases or not, but we moved to theatre at about 12 o'clock and 12 o'clock midday. This is your theatre CTG. Spinal at 12:11. Final VE just to see if there was any last quick progress at 12:16 in the morning, midday. 5 centimeters, knife to skin, and then knife to uterus. And at this point, the section was quite was made quicker, purely based off of the fact that we actually had another bordering on bradycardia whilst in theatre. So if you think about the time frame, this CTG started at 12:11 and delivery was 16 minutes later. And it didn't look at this point like there was any signs of recovery from that, but it could well have been to do with the spinal, but we've already got a baby that's showing us some signs of hypoxia prior to that. Would anybody like to guess the gases?
$7.17.
Okay.
Maybe closer to 7 on the arterial.
Okay. So just another question for you all. Now that we've got the benefit of hindsight, would anybody have done anything differently? I'll take that as a no. I totally agree with the decisions that were made. Although the CTG was not one that I would say was a nice one, the somewhat reassuring factors that were happening in between those decelerations did not require the need to sort of expedite delivery a lot quicker. And after the initial prolonged deceleration bradycardia, we did see a lot of reassuring signs afterwards. I think the only thing, looking back on this with my hindsight hat on, is the fact that we did actually have 2 sets of prolonged decelerations, although they were well recovered. Would we maybe have had different management had this been a primate woman? Probably may have been a little bit more quick to deliver. I'm not sure. That's an obstetric decision at the end of the day. I don't know if we would, because after all episodes of, you know, prolonged deceleration, we did have great recovery. So this baby's clearly got some good reserves. So this baby was born with APGARs of 4 and 4. This was the same gas, unfortunately. Born on the 9th centile, required 2 sets of inflation breaths, 1 set of ventilations, and we actually needed to start chest compressions on this neonate as well, which then recovered and started spontaneously breathing and spontaneously oxygenating afterwards, but we needed to CPAP just to keep the SATs at the right level. But yeah, our venous pH was 7.27, base success -6, and a lactate of 5.2. So considering that, you know, the episodes of those sort of prolonged decelerations and the decelerations we had afterwards, not bad considering what the actual picture looked like. And I'd say that the reason we had ended up resuscitating this neonate is probably more due to the acute event that happened post-spinal more than anything else. But you look at the history, we know that this baby is obviously slightly smaller than the average. And at the same time, lots of things going on with mum's medical history and social history as well, which definitely could have contributed.
How long was
How
baby
was-
in hospital for?
Sorry. Yeah, no, go for it, please.
I was just wondering how long baby was in the unit for overall.
A difficult question because there was social reasons for the prolonged admission. But the baby, I believe, came off of oxygen support after 2 days or 48 hours.
And how is baby now, Carl?
Very well. Very well
Yeah.
and happy.
Because I remember asking about the baby, they said because of the cocaine, baby might have had some withdrawal and was fitting.
Yeah. Yeah, this baby was very unwell for at least the first 48 hours. However, baby's made a good recovery now.
And they were saying also it grew some bad kind of septicemia. I can't remember. It was like staph something.
Yeah, it was in the baby's blood cultures. But
Yeah,
also we
yeah.
queried choreo at delivery just because of the really foul,
Yeah,
offensive smelling
yeah.
liquor.
Yes, exactly. So, but you say baby made a good recovery. There is no signs of anything really.
Not at the moment, no.
Yeah. Okay. Good. Good. Yeah. Yeah.
Do they know if she'd used any drugs like at admission or just prior to admission?
So nothing is sort of proven. But the midwives did believe that she was using in between those 2 initial CTGs that we had in triage, and that the reason she declined further CTG when she initially came in was because she went outside to use and then come back in, and it was believed to be crack.
What kind of things would we see on a CTG if a mum had been using?
The things that you'd see is like there's not sort of a definitive oh, you'll see a higher baseline for gestation, anything like that. But if you think those kinds of medications, those kinds of drugs have a massive impact on the patient itself, and they do pass through to the placenta. So what you'll often see is a fetus that doesn't necessarily have as good reserves, that may go under stress a lot quicker than your healthy average neonate. Also, I guess because of the fact that, you know, things like heroin and crack cocaine do affect your central nervous system, you're much more likely to see things like reduced variability. on the CTG. It's not something that we see very commonly when it comes to CTG interpretation. But if you think of it a bit like how pethidine affects your central nervous system and can reduce your variability, things like heroin and crack cocaine are going to do pretty much the exact same thing, but to a much more damaging extent and probably longer lasting when the neonate is born as opposed to pethidine.
I would say, yeah, I would say also it's a mixed picture. So the according to the purity of the drugs that you are using, because most of those drugs are not pure. So it might cause a bit of like sedative effect, as Kara says, but also if it is mixed with some of the amphetamines and this kind of things that can stimulate the nervous system and make, like hyper activity. And this is possibly the reason why the baseline was wandering up and down, because there is a mix of uh, like adrenaline and amphetamines and this. In addition, um, the, the in this case, as I was involved in as well, I must admit, the difficulty was combined difficulty that somebody is presenting with a previous history of cardiac arrest, and the last thing is to try is to just like do a cat one on her and put her to sleep because of the induction of anesthesia, and the recovery from anesthesia is quite causes some high blood pressure, in addition to having had 4 vaginal deliveries, in addition to um, a lack of cooperation from her side, as she was going out and in, and she was withdrawing herself, which causes withdrawal symptoms and irritability, as she was irritable. Also, all this cocaine, heroin, and drug abuse cause abruption. So one of the things that they can cause also, as one of the colleagues mentioned, some irritability on the uterus. So all this goes into your mind. Is she abrupting? Okay, but there is no bleeding. There is a resting tone. Right. Is she going to progress quickly because she's para 4? Okay, fine. Let her progress quickly. And that's why, as you can see, from, like, luckily me and Kara were on that day. And from the time of the start of monitoring and getting her out of theater to the time she went in is not more than 3 to 4 hours. We didn't leave her to progress on her own, even that the CTG was not a dire one to go to theater, but we felt like if she hasn't progressed to 8, 9 fully dilated in this small amount of time, she will not do it. And all what she was doing is she was kicking a huge dilemma into, in addition to the partner that unfortunately also is not her partner, but uh, like uh, I forgot the name they called him, but it's a kind of person who makes her work as a sex worker. So it is a combination of social, drug, and obstetric, and fetal. And as you can see, the 2210 baby is very small for her and being premature with no liquor draining and or clear liquor. Then you think, okay, at least it should be some meconium. At least you should see some pyrexia. There was no pyrexia in labor to identify chorioamnionitis. So there was no obvious things to see, and the reason behind that is the fact that the clinical picture that you would see normally in any human being is masked by multiple factors, being Shrom, being small baby, being a drug addict, being living in a very socially bad situation. The status that she was on when she arrived is quite horrible. You know, like if you see her status, her hair, her teeth, her physical status is somebody who has been neglected. Yeah, so, but if we talk medically, this cocaine, crack, amphetamines, all these things cause abruption, cause wandering baseline, cause a mixture of sedation and excitability in the central nervous system. It is a very difficult one to interpret on the CTG.
Thank you, Mr. Naguib. Does anybody have any additional questions or anything today?
I wanted to add one more thing that I learned from the pediatrician. When the baby had a seizure in the neonatal unit, the consultant pediatrician mentioned to me that they are going to do some scans of the brain of the baby, as cocaine can cause intrauterine stroke. I didn't know that information.
I remember them
So,
saying that. Yeah.
yeah, so it is quite useful information to know that stroke intrauterine can cause quite a lack of variability on on the CTG, which we didn't have. But I mean, quite a useful piece of information that I will keep in my mind in the future in case of especially heroin and cocaine.
Thank you so much, Mr. Naguib. Thank you, everybody, for joining this evening. I will see you all next week.
Thank you so much, Cara.
Thanks.
Very lovely one. Thank you.
Really interesting. Thank you, Cara.
No worries.